Good morning, all. I just want to say thank you for tuning in to the Scleroderma Foundation Michigan chapter webinar. And I want to first of all thank Dr. Girgis for taking the time for doing this with us today on a presentation of pulmonologists and scleroderma. And also like to thank Michael for being our patient advocate and taking the time out of his schedule to help others with this. So with that, I'll turn it over to Michael for the official introductions of today's seminar.
Good morning. Once again, Michael Bessert, Scleroderma patient advocate. I would like to welcome everyone to the Scleroderma Foundation Michigan chapter's web-based educational series. This webinar is being offered as part of our strategic planning efforts to move towards web-based learning experiences for the next 4 years in an effort to reach more patients, caregivers, and family members who are seeking to obtain accurate information about scleroderma. These webinars reach scleroderma patients and their family members from all over the world, emphasizing the importance of quality educational programming for the scleroderma community. This educational program is made possible in parts by grants from Ectelon Pharmaceuticals US Incorporated and Boehringer Ingelheim and the Treacle Foundation. We thank them for all their continued support. This webinar we have today is Dr. Girgis. Dr. Girgis received his medical degree from Cairo University in Egypt. He completed an internal medicine residency and fellowship in pulmonary and critical care medicine at Henry Ford Hospital in Detroit, Michigan, followed by an advanced fellowship in lung and heart-lung transplantation at Stanford University. He currently serves as the medical director of lung transplantation and pulmonary hypertension at Spectrum Health in Grand Rapids, Michigan, and is professor of medicine at Michigan State University College of Human Medicine. Dr. Girgis has been involved in the field of pulmonary vascular disease and lung transplantations for nearly 26 years and is recognized as an expert in these fields. He has an extensive track record for successful research in pulmonary hypertension and lung transplantation with over 100 peer-reviewed publications. He has a particular interest in scleroderma lung involvement. Dr. Girgis.
Thank you so much, Michael and John. It's a pleasure to be here. As mentioned, been involved one way or another in the care of scleroderma patients for quite some time. I've worked with a lot of wonderful rheumatologists over the course of my career with particular expertise in scleroderma. So it's really a pleasure to be here, and hopefully can provide some information that'll be helpful. So this is, I think the formal title of the talk that you may have had is how scleroderma affects the lungs. So that's what we're going to be talking about today. We'll go ahead and begin, please. Next slide. So how can the lung be involved in a patient with scleroderma? And the way we would first suspect that is based on symptoms. So that can include trouble breathing, can include cough, maybe chest pain, wheezing, fatigue. And then sometimes when in these last symptoms are more related to trouble with high blood pressure in the lung, leading to effects on the right side of the heart, as we'll discuss, but that can lead to fluid retention with swelling in the legs and abdomen. It sometimes leads to heart palpitations or a feeling of fluttering in the heart, and lightheadedness or even sometimes fainting, particularly with activity. Next slide. So just want to review what the anatomy of the lung. So when we talk about how any disease affects the lung, we understand where the problem arises. So you can see here that there's a right lung and a left lung, obviously. But looking at the microscopic level, of course, the lung, it's the main function of the lung is for oxygen in the inspired air to be transferred from the air spaces inside the lung to the blood cells that are in the capillaries with blood. And then the carbon dioxide goes in the opposite direction, leaving the blood going into the air for it to be exhaled in breath. So that's what the lung does. Next. And this is a schematic of how the blood circulates through the body. And that's important when we talk about pulmonary hypertension. So we can start out anywhere in this circle, but let's start out down here in the veins. So blood leaves all the different tissues. It gets collected in the veins here towards the left side of the screen. And so these large veins then collect, and then they empty into the right side of the heart, this blue side of the heart here. And then from there, it's pumped into the lung, into the pulmonary circulation. And there, it divides up into thousands of tiny capillaries. And that's where it picks up oxygen and gets rid of carbon dioxide with the gas that's inside the lung. So it's important to then recognize that in the lung, there is a totally separate circulation. We call that the pulmonary circulation. Then the blood is collected again back after it exits the lung now. And notice now the color of the blood is red because it's picked up oxygen. And it's collected and goes to the left side of the heart. Left side of the heart then pumps it then into the main arteries of the body, and then that goes to every other organ in the body. So brain, kidneys, heart, muscle, and it divides again into thousands of tiny capillaries in every organ. And we call that the systemic circulation. Okay. So when, for example, when someone says that when we refer to high blood pressure or hypertension, we are generally saying that there is systemic hypertension. There's high blood pressure in the arteries of the systemic circulation, and we measure that in the arm because that's a systemic artery. But pulmonary hypertension, on the other hand, that refers to blood pressure that's elevated back up here in the pulmonary circuit. Okay, so it's different. So sometimes there's some confusion there. And there's really not any relationship between pulmonary hypertension and systemic hypertension. So totally different problems. The pulmonary hypertension, it's going to affect the right side of the heart because the right side of the heart here in blue is pumping against the lungs. And that's where the high pressure is. Whereas systemic hypertension, it's causing an increased load or force to contract against from the left side of the heart here and left. So systemic hypertension gives you left heart problems. Pulmonary hypertension gives you right heart problems. Okay, next slide, please. And as we can, again, just kind of more schematics to understand how the structure of the lung is. If we look here this on the lower left, we see an airway coming down. So this is a bronchus, or call a bronchiole, so it's getting smaller. Small bronchus, as it gets smaller, it's called a bronchiole. And then it goes out and then supplies the air to these alveoli, or these tiny air sacs here. And then around every air sac, there's these capillaries where the gas can exchange. So notice along this bronchiole, there's both, there's a pulmonary artery and a pulmonary vein. And again, notice that the pulmonary artery here is in blue because the blood does not, or is oxygen poor. Whereas the pulmonary vein, it's colored in red because it has now oxygenated blood. So I think the point of looking at this is to understand that airflow going through the bronchiole is tightly regulated with blood flow. So that's a very important function of the lungs. In order to have proper gas exchange, we have to match airflow or ventilation with blood flow or perfusion. So call that matching of ventilation and perfusion. And any lung disease will alter that relationship, or can alter that relationship, and cause problems with gas exchange, shortness of breath, and other problems. Okay, next slide, please. So now that we've kind of briefly reviewed lung structure and function, how can scleroderma affect the lungs? So the most common is what we call pulmonary fibrosis, which means scarring of the lung. And this is also referred to often as what's called interstitial lung disease, or ILD. You may also hear referred to as interstitial pneumonitis. That's all those are the same things, where we have a process that is involving, there is scar tissue and or inflammation that's involving the air spaces, or these tiny air sacs, and the space in between those air sacs called the interstitium. So that's most common. The second most common is pulmonary hypertension. There's high blood pressure in that lung circulation that I was referring to. And this is caused by thickening and narrowing, thickening of the walls of those small pulmonary blood vessels, leading to narrowing of their lumen and therefore an increase in the pressure. Next slide, please. So a few comments about pulmonary fibrosis. So this scar tissue that is involving the air spaces and the interstitium results in stiffening of the lung, because the scar tissue is stiff. Normally the lung is very elastic structure. It doesn't take a lot of effort to expand it. But when it has the scarring in it, now it becomes stiff. It requires a lot more effort on an individual's part to expand the chest and move the lung out, because it's stiff, in order for it to get air. So that makes it more difficult, and ultimately leads to actually a reduction in the amount of air that lung can hold. Symptoms are shortness of breath and cough would be the most common symptoms. Now, the prevalence in scleroderma patients, depending on how you define it, is actually pretty common, but the severity is quite variable. So many patients with scleroderma have a very mild form of it that can only be detected by a highly sensitive CAT scan of the chest. But it's not very severe, and they may not have any symptoms at all. But in about 10% of patients with scleroderma, they have significant disease that would be considered severe.
Doctor, can I ask you a question? What type of tests do you normally run to monitor a scleroderma patient once they've been diagnosed over the first 5 years, to see whether or not they might be developing some fibrosis?
Yes, we're going to talk about that coming up.
Oh, okay, great. Thank you.
Yep. Pulmonary fibrosis is generally more common and severe in patients who have more diffuse skin involvement from their scleroderma. So you may be aware that the skin involvement in scleroderma is generally classified into a diffuse subtype, where the skin involvement is proximal to the elbows and knees, so includes the trunk, and the limited variety, where all the skin changes are mainly in the distal extremities, so the fingers. Pulmonary fibrosis can occur in either diffuse or limited skin involvement, but tends to be more common and severe with diffuse disease. Also, it's more severe and common in people who have this SCL70 antibody, so it's a blood test that correlates more with the presence of pulmonary fibrosis. And African-American males, as a demographic, tend to have more common and severe pulmonary fibrosis. Now, the onset of the pulmonary fibrosis is typically early, within the first 5 years of diagnosis. Next slide. So here's what's happening. So if you look microscopically, again, here's these tiny alveoli. If you could, up here, these circular structures, this is the alveoli, cross-section of them. And then the walls in between every alveolus is nice and thin. It's barely perceptible, and there are these red areas, those are the capillaries with the blood flowing in between. So that's how it normally should look like. Go down to the bottom, now we see that this nice, bottom right, we see that this nice fine alveolar structure has been disrupted. So the architecture is disrupted because of scar tissue. So instead of having a bunch of tiny, small alveolar sacs, we have these kind of irregular and large cystic areas, okay? And then in between, instead of having these nice thin interstitium, we have this dense scar tissue. in brown here. That is the scar tissue. So we're kind of, there's some destruction or alteration in the architecture of the alveolar structures, and there's scarring in between those alveoli. So that is the pathology, the abnormal structure. Next slide, please. So how do we assess a patient and make a diagnosis? So we talked about symptoms. So the next thing is a physical exam. We listen to the patient. You may have, some people may be familiar when we hear crackles, when we listen with the stethoscope. And on a chest x-ray, we see abnormal shadows that take the form of fine lines or linear, we'll call linear opacities. But really the best way to, really the kind of, at least the standard clinical tool to make this diagnosis is what's called a high resolution computed tomography, or HRCT, of the chest. And this is a dedicated way to do the CAT scan, or to reprocess the CAT scan images that are obtained, so that we get high resolution, very thin cuts that gives us the best image of the lung architecture. And so again, we see linear opacities suggesting the scar tissue. And then sometimes we also see more hazy, or what we call ground glass opacity. So if you take glass and crush it, what that would look like. And that may be, if we see that, that could suggest some active inflammation as opposed to scar tissue. And then we have, so the CAT scan gives us a good understanding of the structure of the lung. And we do a pulmonary function test to assess its function. Next slide, please. So on your left is an example of a HRCT from a normal individual. So this is down towards the base of the lung. Over here on the right, the white, towards the right end of this image, towards the right end of the image, all the way actually all the way to the left. All the way to the left, and then there's, so that the white structure, that's the liver, so that's white because it has up in the front, towards the front. Yes, right there. So that is the liver, okay? And then behind the liver, we have the black density, we have the black color underneath the liver. We have the black area, that is the lung. Yeah, right there. So that's the lung, and it's black because it has air in it, and the liver is white because it's water density. And then within the lung, that black area, there's these kind of linear and circular white areas throughout. And those are that's just the normal markings that the airways and the blood vessels have. So that is a normal appearance. Contrast that with the image on the right side. It looks a lot different. Now we have many more linear opacities, and we have distortion of the architecture of the lung on both sides. Both the right and left lung bases have that change. So that would be a very typical pattern to see on a high resolution CT scan that would indicate pulmonary fibrosis. And if you have a patient that is known to have scleroderma, then we've established our diagnosis. We can say that the patient has pulmonary fibrosis associated with their scleroderma. Okay, next slide, please. Now that is again, the structure. We image it with the CT scan. The next thing we need to do is assess its function. And so we need to do a pulmonary function test. So many of you, I'm sure, have had these. So you have the respiratory therapist, the pulmonary function technician. In the upper left here is a spirometry. So you sit down upright with your feet on the ground, really take a big deep breath in, fill the lungs in all the way, blow out as much as you can to empty the lung, and that gives us an assessment of your lung capacity. Sometimes we'll ask for full lung volumes, and that requires use of what's called this body box here on the lower right, where you sit, and it's just an airtight chamber. Okay, next slide, please. And so we don't need to go through the details, but if people are interested, so there's different subdivisions of lung volume, but the main one that we measure very frequently in this setting is the vital capacity. So Again, the vital capacity. So if you can just imagine here, we can start out on the left of this figure, and there's the tidal volume. So this is just a tracing. So the individual has the mouthpiece in and they're just breathing normally, regular breaths, and that's called the tidal volume. So with every breath, how much air is going back and forth with every breath. And then you take a deep breath all the way in and fill up the chest all the way up to you get to your total lung capacity. And then you exhale very forcefully and hard and empty out down to the residual volume where you can't exhale anymore. And that difference then between the total lung capacity and the residual volume is the vital capacity here, okay? So that vital capacity is what is a highly reproducible number, meaning that we can measure it in an individual on multiple occasions and we get consistent results. And it tracks very well with the disease process and has a lot of prognostic importance, and it's responsive to interventions of therapy. So you'll see that your rheumatologist as well as your pulmonologist will be giving a lot of attention to the vital capacity, or sometimes it's called the forced vital capacity because you blow out hard to generate that. And so we call it the FVC for short. So that FVC is a very important number to track. And it's very easy to do. So it just requires taking a deep breath and blowing out. Okay, next slide, please. So what are the pulmonary function abnormalities that we see in someone with interstitial lung disease of any variety, including pulmonary fibrosis associated with scleroderma? So the first thing is that we see a reduction in the amount of air that the lung can hold, or a reduction in lung volumes. And that's most frequently ascertained or quantitated by what I just described, the forced vital capacity, or FVC. And when we obtain any lung function measurement, we get a number. So in terms of volume, we get how much air is there in liters. So we get a forced vital capacity measurement and it'll come out as 3 liters. So in order to understand whether that's normal or abnormal, we need to index it for the gender and height. Because obviously, the taller you are, the larger your lung volumes are going to be expected. So we express the forced vital capacity as a percent of the predicted value. And if it's less than 70% of predicted, then that will be considered abnormal. But there can still be abnormalities in someone with an FVC of greater than 70% predicted, particularly if we're looking at it for the first time. So a forced vital capacity of 95% of predicted could be abnormal for certain individuals because they could have started out at a higher value. So not only is the current value important, but following it serially is very important to look for change in an individual patient. And so forced vital capacity is most important, and also the total lung capacity would also be decreased if that's measured. Another very important number on lung function testing is what's called the diffusing capacity. It's called the DLCO, which stands for the diffusing capacity of the lung for carbon monoxide. So in this test, it's a bit more complicated than the vital capacity maneuver, but it involves taking in a breath, breathing in a gas mixture that has tiny, minute quantities of carbon monoxide. And then the patient inhales, fills their lung, and holds their breath for 10 seconds. And then they exhale, and then we measure the carbon monoxide in the gas in the air that's exhaled. And so we're trying to figure out how much carbon monoxide did the lung take up. And we use carbon monoxide as a surrogate for oxygen because it's highly soluble. The lung takes up carbon monoxide quite readily. So it's not dangerous because we're just using a tiny amount, but it gives us a good idea about how well is the lung able to take up oxygen. And it's going to be decreased in the setting of interstitial lung disease because there's that thickening of the space in between the gas in the alveolar space and the blood in the capillaries. Okay, so these are the two main, I'm sorry, back up please once. So when we talk about interstitial lung disease, the two parameters that we follow most closely is the forced vital capacity, FVC, and the DLCO. Okay, next slide, please. So what about treatment for interstitial lung disease? So as I mentioned, that most cases, the majority of patients with scleroderma who have pulmonary fibrosis or ILD, it'll be pretty mild. It's something that we just detect on CAT scan, or they may have some mild pulmonary function abnormalities, but it's stable, it's not progressing, and really just observe it. On the other hand, in that subset of patients that have progressive disease, so their vital capacity and or their DLCO is falling, the extent of CAT scan abnormalities is significant, and the patient's symptomatic with shortness of breath or cough, then treatment is generally indicated. And the first thing that I think most rheumatologists, and this is of course done in collaboration with your rheumatologist, but I think the consensus is still that some type of immunosuppressive therapy is maybe beneficial. And the options that we have are mycophenolate or Cellcept, cyclophosphamide or Cytoxan, or azathioprine or Imuran. One of those could be considered. Next slide, please. This was data from a study that compared, so this is what's called the Scleroderma lung study. And I'm showing you data for SLS2. SLS1 was a study that compared cyclophosphamide versus placebo and had shown that cyclophosphamide led to some small improvements in vital capacity compared to placebo, but it was significant. But cyclophosphamide, I mean, it's kind of a tough drug to use. It's very toxic. People don't like to give it for more than a year. Mycophenolate, on the other hand, is a bit better tolerated, and there's more long-term safety data with it. So for this study, SLS2, they wanted to compare mycophenolate with cyclophosphamide, and showed that they were basically equivalent. So here, what's showing here that at baseline, where there was, compared with baseline, that both groups, cyclophosphamide in red and the mycophenolate in blue, there is improvement in the vital capacity, but it's small. So we went from a mean of around here 66 up to 69 to 70, so small changes. So, but what this study established that mycophenolate is just as good as its effect on lung function as cyclophosphamide, and it's safer and can be used for a longer period of time. Next slide. So mycophenolate is standard. I think it's probably first-line therapy for scleroderma patients with interstitial lung disease. Side effects of it, it's an immunosuppressant, so there could be an increased risk of infections. It can decrease the white blood cell count. Not uncommon to have various stomach upset symptoms, nausea, sometimes diarrhea. Maybe an increased risk of malignancy when used for a very long time. And so, perhaps it's people use it for 2-3 years and then kind of give a break and then see how things go. And again, the long-term use has not been established really yet. Next slide. So I'm sorry, this version did not include an addition. We'll go back one slide, please. Okay. So there's mycophenolate, and now that was kind of what we had, up until recently. Sometimes rheumatologists will use rituximab, which is an infusional drug that's given by injection periodically. That also acts as an immune suppressant drug. More recently, last year, there was a study of a drug called nintedanib or Ofev, which had been previously shown to have some utility in idiopathic pulmonary fibrosis. So what we're talking about now is pulmonary fibrosis associated with scleroderma, which can look a lot like pulmonary fibrosis in people who don't have scleroderma and don't have any other underlying condition. We call that disease idiopathic pulmonary fibrosis, or IPF. And in that disease, there's two what we call antifibrotic drugs that have been studied in IPF and shown to be effective, and both of them are on the market and FDA labeled. So the first one is pirfenidone or Esbriet. And then the second one is nintedanib or Ofev. And both of them, so Ofev has been specifically studied in scleroderma-related interstitial lung disease and has been shown and had some positive benefits, mainly some improvement or at least stabilization in the forced vital capacity compared with placebo, and has gotten FDA approval for specifically scleroderma-associated interstitial lung disease. So that's another option now, is Ofev. And then Esbriet, the other antifibrotic on the market, is currently in a clinical trial in scleroderma patients. So that may show some effect too. So, and that study that studied Ofev actually included many of the patients in that study were already on mycophenolate as well. And now, in the group that was getting mycophenolate, it looked like the benefit was smaller, which makes sense. So if you're not on anything and you get something new, the effect is larger. So I think, this is new information now, and it's not clear, how we should be using mycophenolate versus Ofev. Do we use them together? Do we use one at a time? So I think that is something that is still to be determined. Okay, next slide, please. So that was talking about pulmonary fibrosis. Pulmonary hypertension, as I said, is the second most common way that scleroderma affects the lungs. So how do we define pulmonary hypertension? So it's an elevation in the pulmonary artery pressure. The normal values up to about 20 millimeters of mercury, the mean pulmonary artery pressure, which we measure with, we'll talk about with the right heart catheterization. So when it's much above 20 or 25, then we say that it's abnormally elevated. And what's happening is that there's thickening of the walls of these small pulmonary arteries, resulting in narrowing and increased resistance to blood flow, so the pulmonary pressure has to go up. And the main impact on that is that it creates a lot of load or increased resistance to ejection of blood from the right side of the heart. And it tries to compensate for that by increasing the amount of muscle. It's normally not used to that pressure being high like that, so it can't struggle with it. So it ultimately can dilate and fail. So the main impact of pulmonary hypertension is not on the lungs per se, but on the right side of the heart and the effects that it has on the function of the right heart. Next slide, please. The slide was just out of order, I'm sorry. So, this is the nintedanib study that I referred to, or Ofev. So this was referred to as the Census trial. It was published in the New England Journal of Medicine. And then again, looking at the change in vital capacity, FVC here on the left axis. Go ahead and point to that, please. Yes. So what we're looking at is change in the forced vital capacity, or FVC. And remember, I said that is the most reliable number that we follow, and it really tracks well with symptoms and changes in therapy. Okay, and then we have two groups, one that got the nintedanib in dark blue, and then the other group got placebo in light blue. And you can see over the course, the study was done over 52 weeks, so we have time on the x-axis. And you can see down here at the bottom the number of patients in each group. So this was a large study. At the beginning, we have 288 patients in each group. So pretty large study, actually. This is much larger than really any other study that's been done in this patient population. And while both groups had some decline in their forced vital capacity over the course of a year, the nintedanib had better preservation in that. So the placebo group lost more lung function over the course of the 52 weeks compared to nintedanib. So based on this data, then Ofev does have an FDA label for use in scleroderma interstitial lung disease. Okay? All right, sorry about that. So now we're back to talking about pulmonary hypertension. So again, understanding what's happening. If we look at the left-sided panel here, the far left is a cross-section of a normal small pulmonary artery here in the middle of the left-hand panel. The wall is nice and thin, and if we go to this nice circle, the wall is nice and thin, and in the middle we have a nice wide open lumen for blood to pass through. And we contrast it on the one next to it, then we have this thickening of the wall with encroachment on the lumen. And as we go lower down, it gets worse. So you can imagine that trying to get blood through there, if we want to try to push the same amount of blood through there in terms of flow rate, then the pressure must go up. And so the pressure is high inside that artery. And the impact that this has then, if we look at the right-hand panel, again, it's related to the effects on the right ventricle. So let's look at the top right cartoon here. See that the right ventricle here on the right there, yes, RV has a nice thin wall under normal circumstances. And then go down a little bit and we see the same image in cross section. So the RV right there, no, a little bit higher, right there. So the LV is the left ventricle, RV is the right ventricle. So the LV, it normally has a lot of muscle around it because it's pushing blood against the high pressure of the systemic circulation. So systemic circulation, your normal blood pressure is 120/80. But in the pulmonary circulation, normal pressure is about 25/10. So naturally, a very lower resistance, lower pressure circuit. So therefore, there's not much muscle around the right ventricle. You could point to that same figure that you were, yes, to the right ventricular wall, RV, the wall is nice and thin. Now, when the pressure goes up, then we'll just go, yeah, see that the RV now is nice, is thickened because of the high pressure. And ultimately, it could fail. So next slide, please. So pulmonary hypertension, again, it's common, less common than pulmonary fibrosis, but still fairly prevalent. So about 10 to 15% of all patients with scleroderma may have pulmonary hypertension. And in contrast to the fibrosis, which tend to be more common in the diffuse skin disease, here it's more common in limited variety in people that have the anti-centromere antibody. And it's typically noticed after a long duration of disease, so maybe after decades. It can occur in isolation, so by itself, and there where we call it pulmonary arterial hypertension. Or unfortunately, it can occur on top of interstitial lung disease. Symptoms are shortness of breath, fatigue, fainting, and leg swelling. Now, just because the patient has known scleroderma doesn't mean that their pulmonary hypertension is from the scleroderma. We do need to look at other possibilities. In general, some trouble with the left side of the heart is the most common reason that people get pulmonary hypertension. So that always needs to be considered. Other important things to exclude would be a blood clot in the lung. So we need to not assume that the pH is always due to scleroderma and consider other factors.
Are there,
Next slide.
Doctor, before we leave this, are there any differences between pH that we see here with scleroderma patients and maybe pH with patients who maybe were smokers?
So yes, that's a good question. So smokers can have COPD or emphysema, and sometimes that can be complicated by pulmonary hypertension. So there is pulmonary hypertension due to chronic underlying lung disease. And yes, that is different than the pulmonary arterial hypertension that when it occurs in isolation in a scleroderma patient. In that situation, a scleroderma patient who just has the pulmonary hypertension without much in the way of pulmonary fibrosis, the disease is mainly in those small pulmonary arteries, and it's isolated to the vasculature, whereas the rest of the lung tissue is healthy. So yes, it is different than in the example you cited where the pulmonary hypertension complicates an underlying lung disease like emphysema or like pulmonary fibrosis. So I don't want people to get confused. So pulmonary hypertension can complicate people that have pulmonary fibrosis, irrespective of scleroderma. So I mentioned the disease IPF, idiopathic pulmonary fibrosis. That can be complicated by pulmonary hypertension.
Okay.
But it's different than in scleroderma who don't have a lot of pulmonary fibrosis and get pulmonary hypertension. That's why I use the term PAH, and we want to be, so when we say so PAH is pulmonary arterial hypertension. And that is different than PH, which is just pulmonary hypertension. Okay.
Okay, thank you, doctor.
So testing in pulmonary hypertension. So a screening test or a good test that's often done is an echocardiogram, where we're looking at the heart chambers, size and function of the heart chambers, and we're able to estimate the pulmonary pressure there. I mentioned we get an HRCT to assess for the presence of interstitial lung disease. So just back to that last question though, so that, the point that you bring up is very important, because, the responses to therapy are a lot different in patients who just have an isolated type of pulmonary hypertension, and we'll call it pulmonary arterial hypertension or PAH. But when there is a lot of pulmonary fibrosis to begin with, and then on top of that you have pulmonary hypertension, that is probably a different condition. So that we should not be referring to PH in the setting of extensive pulmonary fibrosis as pulmonary arterial hypertension. The term pulmonary arterial hypertension, we want to reserve that term for a condition where we think the disease is mainly focused on the blood vessels, not involving the rest of the lung tissue. And that's important from a treatment standpoint. So it's important that we get an HRCT here to look for the presence and or extent of pulmonary fibrosis. And then we'll ask for what's called a VQ scan or a ventilation perfusion lung scan to screen for blood clots, because we want to rule out the condition referred to as CTEPH or chronic thromboembolic pulmonary hypertension that people get as a result of recurrent blood clots. And then we get a pulmonary function test, and we may typically then, because if there's not fibrosis, we would not expect to see the lung volumes decreased. But what we see that diffusing capacity, or the DLCO, be decreased because the blood flow is not good through the lung. These capillaries in the lung don't have adequate blood in them, so they don't take up the carbon monoxide. It's good to screen for sleep apnea or other types of sleep disordered breathing, because that can be associated with or certainly exacerbate pulmonary hypertension. And we assess the functional assessment with doing what's called a 6-minute walk test, see how far one walks in 6 minutes. Next slide, please. So this is a normal echocardiogram. We have an apical 4-chamber view. Normally I did have a video attached to this, but you see on the right side of the image, there is the right side of the heart. I'm sorry, the left side of the image. On the left side of the image, there's in black here. Yeah, right there. That's the right side of the heart, okay? And then the other chamber to your right is going to be the left side of the heart. You see the right side of the heart is typically a little bit smaller than the left side of the heart, okay? Next slide, please. In contrast this to someone with bad pulmonary hypertension, you can see the obvious difference that the right side of the heart is dramatically enlarged. And if I could show you the motion of it, you can see that its pump function is also a lot different than the normal situation. So echocardiogram can show us the size and function. Oh, looks like it is good.
Yep. If you want, we can.
Yeah, let's go back to the previous one then.
Okay, let's
go back to the previous slide.
We are on there.
All right, so yeah, let's look at this one. So yeah, just let this run. Mm-hmm. Yeah, so we see here both sides of the heart are contracting nicely, nice squeezing robustly. Okay, now let's look at contrast it with the next one. All right, see how that right side of the heart is just, it's moving much more sluggishly, not squeezing as we saw with the previous. Now, but notice that the left side of the heart is squeezing nicely. That small left side is squeezing, but that right side is just under a lot of duress and it can't really generate that contraction. Okay? So nice, easy, simple, non-invasive way to assess the size and function of the right side of the heart. Okay? Next slide. And then the other thing it can do for us is provide an estimate of what the pressure is. And for those of you that are interested, look at the left-sided panel here with the color. This is where there's the right ventricle towards the top part of the image, and then the right atrium towards the bottom part of the image. So as the blood is circulating through the heart, when the right ventricle contracts, the blood should be going forward to the lung. Some of it ends up leaking back into the right atrium. So there's this valve in between these two that's referred to as the tricuspid valve. So if there's any degree of regurgitant jet, then we can quantitate that and then see how fast the flow velocity. So in the image to the right, we're actually finding that area of tricuspid, we call tricuspid regurgitation, and then show the image on the right here. We'll go to the right. Bring your arrow to the right side of the slide. Yes, that one. So here we're capturing that, and we're looking at the velocity of blood that's going through that tricuspid valve with every cardiac beat. And the higher that velocity, that means the greater pressure gradient between those two chambers, meaning the higher the pressure inside the right ventricle. So it's a good way to provide an estimate for what we call the right ventricular systolic pressure. So RVSP stands for right ventricular systolic pressure. And it should be the same as the pulmonary artery systolic pressure, which is PASP. So it's a way to estimate that top number. You take your blood pressure in your arm, you get a blood pressure, you get a systolic and diastolic, 120/80. I said in the lung, typical pressure may be 25/15. So the echo provides an estimate of the right ventricular or pulmonary artery systolic pressure. And if it's normally should be less than 30. If it's 40, 50, 60, then we know that we at least suspect that there is high pressure in the lung. And so it's a way to screen for pulmonary hypertension. Next slide, please. But the way to confirm it, though, and get additional information is with what's called the right heart catheterization. This is pressure inside the chest, so we can't measure it as we do with systemic blood pressure. But this is even though it's an invasive procedure, it's quite safe. And what it involves is, if we just look at this cartoon, we see this to the left of that cartoon, there's that yellow catheter going into the blue vein. So we typically do the procedure from the neck, a catheter is inserted through the jugular vein, and then it's passed through to the right side of the heart, and then it floats up into the lung and into the pulmonary artery. And then when it's hooked up to a pressure transducer, we can directly measure. So now we get the systolic and diastolic and the mean. And also the catheter has a flow sensors on it, or has a way that we can measure flow and therefore cardiac output, how much blood is flowing through the circulation.
Now, Michael, you've had this procedure, haven't you?
Yes, I've had 2 of them. And yeah, very easy to do. Non-invasive, like you said. They just give you a little numbing sensation in your neck and your cardiac artery, and relax until I had to do the stress test too. So, yep, I tell people all the time not to be afraid of it, because it needs to be done, and it's the only way they can establish it. It's a great thing to do. So, yes.
Yeah, well, thank you for sharing that. I mean, I think that's very helpful to hear. Yeah, it sounds like it's a big deal because you're putting a catheter, and tell people we're going to put a catheter inside your heart, but it really is quite safe.
Right.
Done under local anesthesia. Generally does not require any sedation.
Yeah.
And so pretty safe test. Really, the main risks of it, the most common, if there's going to be a risk, the main risk is bleeding or bruising at the site of the venous puncture. And nowadays, we use ultrasound guidance to puncture the vein. And so it's very rare, really, for us to even have that problem anymore. Next slide, please. So once we establish, so the point of showing the right heart catheter is that is required to establish a diagnosis. We can't make the diagnosis without the right heart catheterization. even if the echocardiogram is highly suggestive. You always want to have the right heart catheter because it provides additional information above and beyond. So we use the echocardiogram and the right heart cath in a complementary fashion. They give us different pieces of information. Once we establish a diagnosis, what can we do? So general measures. Again, if the right heart is under a lot of stress, it can be associated with some fluid retention. So diuretics can be quite useful to relieve that. If the oxygen level is low, providing supplemental oxygen is certainly important. Women of childbearing age should be counseled very strongly to avoid pregnancy because it has a high risk of not going well. And importantly, we want to avoid drugs that impair heart function. So there are a lot of drugs that are used in people with heart disease, and specifically things like a beta blocker, metoprolol, and other things. And then certain calcium channel blockers like verapamil or diltiazem. These drugs are known to have, and sometimes that is part of their therapies, that we want to reduce contraction of the heart. So for example, metoprolol and other beta blockers are extremely useful in people with coronary artery disease who've had a heart attack, where we don't want that heart to contract vigorously. But if the right ventricle is already impaired, the function of it is impaired because of the pulmonary hypertension, then that could make matters worse. So it's important to review the medications and make sure that none of them are going to have any untoward consequences on the right side of the heart. So those are kind of general measures. And then the next thing to consider, we do have actually several medications that have been studied and shown to be effective in pulmonary arterial hypertension, again, the term PAH. Because if it's a situation where the pulmonary hypertension is combined with significant interstitial lung disease, we don't have data on using these medications in that setting. Next slide. So these are the drugs that are on the market currently. They're categorized into different pharmacological groups. So we have the prostacyclin analogs here on the left. And the first one that became available was intravenous epoprostenol. That's given as a continuous intravenous infusion. So that was the first drug that was shown to be useful in PAH. And that came out, I think, in about 1995. All right. So for a while, that's all we had. But then we had, that has to be given as a continuous intravenous infusion 24/7. So it can be cumbersome, but it can be highly effective. And so even though it's a cumbersome therapy, it still is considered the gold standard and the most effective drug. And then we have variations on it. We have treprostinil or Remodulin that has the advantage that it can be given subcutaneously instead of intravenously, but may not be as effective by that route. We have Remodulin is also available to be given by inhalation under the brand name Tyvaso. And we have treprostinil now available to be given by pill form, and it's called Orenitram. So a lot of different ways to give treprostinil. And then we also have another prostacyclin analog called Selexipag that also works on that same pathway, and that's called Uptravi. So we have different prostacyclin analogs. They can be given either intravenously, subcutaneously, by inhalation, or by mouth. And then we have the endothelin receptor antagonists. First one to become available was bosantan or Tracleer, which is rarely used nowadays. Now we have kind of better tolerated ones, which is ambrisantan and macitentan, or Letairis and Opsumit. So one can use one of those drugs. And then the next category is what's called the PDE5, which stands for phosphodiesterase type 5 inhibitors. And the prototype there is sildenafil, better known as Viagra. But when it's on the market for pulmonary hypertension, they've given it a different trade name and called it Revatio. But it is Viagra, it's the same drug. And then we have tadalafil, which is Cialis, and that comes under the trade name Adcirca. And then the final drug is riociguat or Adempas, which is called a soluble guanylate cyclase stimulator. That's the type of drug that it is. And that is very similar, or at least it's the same pathway as the PDE5 inhibitor. So you wouldn't be on both sildenafil and Adempas, for example. Be one or the other. Any of these or all of these are approved for and have been shown to be effective in PAH, including patients with scleroderma. The trend now is to use them in combination. So next slide, please. And this is, kind of the best study that's shown us that using two is better than one. Two drugs is better than one. So this was a study, this was the Ambition trial that compared, the combination therapy group, so we compared two groups of patients. One got combination therapy, and in this study, it was the combination of ambrisentan plus tadalafil, so an endothelin receptor blocker plus a PDE5 inhibitor, compared to either one of those drugs alone. So in the monotherapy group, some patients just got ambrisentan, others just got tadalafil, and what the dotted green line is showing is the pooled monotherapy group. And this was a long study here. The x-axis is in weeks. It was a large study, so about 250 patients in each group. The primary outcome and what this graph is showing us, this was basically, it was a composite primary endpoint that tried to measure disease worsening, some type of clinical deterioration, okay? So you can see that the combination therapy group had a lower incidence of getting worse compared to the pooled monotherapy group. And then with statistical analysis, actually the hazard ratio was 0.5. So people who got the combination therapy group had a 1/2 chance of getting worse compared to the pooled monotherapy group. So based on this data and some other data, it's preferred to begin with a combination approach. Now, before this type of data, what the standard approach to therapy to pick one drug out of that list and then see how the patient does, and then if they're not responding or they're getting worse, then add another drug, add a second drug, and then if they're still getting worse, add a third drug. But now we know from this data that it's best to use certainly 2 drugs up front. It may be best to use 3 drugs up front, but we don't have that information. But you can be on up to 3 drugs.
Doctor, the one question I have is, being an engineer at heart, I've noticed the one thing is that here we started with basically 250, and basically after a little bit less than 2 years, we're less than 40% of each. We're down to 106.77. Is there any reason for seeing the drop off?
Yes, that's just so the way this study was set up is that they didn't actually have a finite duration for how long it was going to last. They said that the statistical analysis said that we're going to keep going until we see a certain number of events that would qualify as the primary endpoint. So when a certain total number of people in any of the groups worsened, once they got to that number, then they stopped the study and did the analysis.
Okay, I understand.
Okay, next slide, please. Next slide.
Mm-hmm. Let me just go back, just to make sure. Hold on.
Oh, okay. Yeah, this should be the next slide then. All right. No, let's go back. Okay.
That was where we were, and your next slide is the effects of oral pH drugs.
Okay, so side effects. Okay. So again, these drugs are, for the most part, well tolerated. I mean, they've been approved, but they can be associated with side effects. So if you're getting an endothelin receptor antagonist, so that would be ambrisentan or macitentan. The most common side effects would be a tendency for fluid retention, so some leg swelling, and maybe mild anemia. PDE5 inhibitors, so sildenafil, headaches, stomach upset, and some rare ocular side effects, maybe blurry vision. A lot of these things are, and then with the prostacyclins, particularly any of the prostacyclins, not just the oral, but headache and GI upset. A lot of these side effects are transient. They start out at the beginning, and then over time, the body gets adjusted to it, and they're not problematic. So, so most of the time, people can stay on these medications, but sometimes these side effects are bad enough that they require stoppage of the treatment.
And one thing too is I have taken a lot of those medications. I've been on CellSup for 7 years. I was originally only supposed to be on it for 5 years, but I responded so well and I could breathe. Basically what I was doing was panting. I had gone into survival mode, and I wasn't doing full breaths, I was panting. But most of it was the skin tightness it was like I said, I was being bear hugged and I couldn't breathe. But I have been on CellSup for 7 years, and Dr. Dinesh Khan is my rheumatologist. And he said, I will probably be on it the rest of my life because they find that people respond to it so well if they take off it, that it tends to bring the scleroderma back with a vengeance. And I've also been on sildenafil, but the reaction part with the GI part is I have diffuse, so I have a lot of GI issues anyway. So sometimes it's hard to differentiate a side effect of a GI issue when you have GI issues normally. You know what I mean? So, but I take both of those very well, and and like I said, CellSept I've only had, they had to cut my dosage in half because it was accentuating, or like my moles, skin tabs were growing at an abnormally fast rate. But we cut back the dosage, and I've been tolerating that very well. So,
Yeah.
but it is hard to differentiate some of the side effects with the actual disease sometimes. But I just wanted to add that part.
Yeah. So thank you so much for that insight. I mean, it's wonderful that you're able to comment on a first-person experience.
Thank you.
So just to clarify for the rest of the listeners, you used the term CellSept. So CellSept is the trade name for mycophenolate, so that people don't get confused there. And so, because earlier I was referring to the duration of therapy with mycophenolate or CellSept, and that's generally handled by the rheumatologist, as it is in your case. And for how long should one stay on it? So you answered that question for us, that it, use it for as long, I guess, as it needs to. But
Right.
as you mentioned, the long-term concern, would be the potential for, induction of some kind of, tumor growth, and so they were concerned about your molds, getting more problematic. So they had some concern about that. The other thing you mentioned is the effect on skin thickening. What I failed to mention with the scleroderma lung studies, with both cyclophosphamide and mycophenolate, in addition to slowing or having the effects on the forced vital capacity in the lung, it also improved skin scores. So skin thickening is impacted by these drugs. And that's in contrast to, I should point out, with nintedanib or OFEV. So that was looked at in the study of OFEB, and there was no impact on skin thickening.
Thank you.
Yeah, and then as far as your comments about the GI side effects, yes. So you all know that the scleroderma affects the gut. So it affects the upper gut in the form of gastroesophageal reflux, dysmotility of the food pipe, or esophageal dysmotility. So certainly people are going to have nausea and upset stomach. And it can affect the lower gastrointestinal tract with small bowel, hypomotility, and diarrhea. So yes, it would be. But so you kind of need to know where you're at baseline, and then start the drug and see if there's been changes.
That's why it's very important that everybody that, as a patient of whether it's scleroderma or anything, they have to be their own advocate. They have to know, like you said, their baseline, what they tolerate, keep notes, keep your doctors informed up to date. Don't just, expect the doctor just to diagnose you. So you have to have your part in helping the doctor and helping him diagnose and establish a baseline to keep you going. So.
Yeah, thank you so much for saying that, because you know, there's nothing more helpful than having a well-informed, well-educated patient
Thank you.
that knows what medications they're taking, why they're taking each medication, and understanding what is going on with them. And that's why, you know, it's hard to understand sometimes, but, you know, but on the other side, it's not hard. I mean,
Right,
I think, and I think that's our job as physicians, to educate patients about, you know, what is it that you have? Why are you feeling this way? What can we expect? Why we want to give you this medication? What we expect this medication to do for you, and how can it affect you in an adverse fashion? That's our
Exactly.
job. And if we're not
Thank you.
doing that, then we've not done our job in educating patients. And so as patients, you just said, you need to be your own advocate. You need to ask these questions. Well, doctor, what can I expect from this medication? What are you trying to achieve with it? Okay. And you need to understand that, because at the end of the day, you are your best advocate.
Exactly. Thank you, sir.
Right, next slide, please. So this is the continuous intravenous epoprostenol. As I mentioned, it has to be given 24/7. So if we look at this particular patient here, if we could go to that photograph and show that he's got this catheter in his chest. So that's a implantable intravenous catheter that's suitable for long-term use. It can stay indefinitely because it's tunneled through the skin, and then it's hooked up to intravenous tubing. And it's hooked up. That tubing is hooked up to the pump there on the lower right. That pump contains the drug there in the lower part. There's that cassette. Lower part of that pump has the cassette with the drug in it that requires to be reconstituted. So, you know, and you see that this patient, you know, has all the setup. He's got the vials, he's got the cassette, and he's loading it. So he's doing a fair amount of work every day, but once he gets the hang of it, takes about a half hour a day to get through this. So it's not too bad. And so, but there are side effects. Having this indwelling catheter can lead to infections, particularly if the catheter site is not taken care of properly. There's delivery system problems, malfunction, kinking, tubing issues, and then drug-related side effects, headache, flushing, and GI upset, as we've already mentioned. Next slide. And then this is subcutaneous Remodulin. So a bit easier to use, safer going under the skin. But this picture on the left side, I can guarantee you that that individual with the lacy underwear is not getting the drug infused in her skin, because the right side is a real picture of the Remodulin going in, and it causes redness and swelling around the injection site, and painful pain around the injection site. So that is a side effect. So that is probably maybe one of the limiting factors in using Remodulin, is sometimes intolerable site pain. But we have ways to deal with that. There's been some modifications in the catheter to make it longer and other things. So catheter site pain is the most important side effect with subcutaneous Remodulin. Again, the delivery system can sometimes malfunction, but it's not as cumbersome or difficult as the intravenous modality. And again, because it's a prostacyclin, similar type of drug-related side effects, namely headache, flushing, and GI upset. Next slide. Now, and then we can give, again, treprostinil, the same drug as the Remodulin, but given by inhalation, and where it's called Tyvaso. So there's the device that is specifically designed to give this medication. And it's fairly simple. You load the drug in that device once a day, and then it's given 4 times daily once you finish loading it. And you take anywhere between 6 to 12 breaths at a time, 4 times daily. So easier than both the intravenous and subcutaneous route, but less effective in general. And it can cause sometimes some cough and throat irritation with the inhalation. And again, if the drug is getting absorbed systemically, we can expect the drug-related side effects of headache and GI upset. This has perhaps some additional rationale to use. So this is different now. We're giving it by inhalation. What I've talked about before was giving the drug either orally or intravenously or subcutaneously. It's going into the systemic circulation. It's going through the entire body. Theoretically, when we give a drug by inhalation, we're just getting it right into the lungs, and it's having its effect there locally with less systemic side effects or systemic effects. And it may have some particular utility in people that have pulmonary hypertension complicating pulmonary fibrosis. And in fact, this drug was recently studied in people with pulmonary fibrosis in general, not specifically scleroderma. So studying people with pulmonary hypertension complicating pulmonary fibrosis. And it hasn't been published yet, but it has been presented, and the preliminary data suggests that it was useful in improving 6-minute walk distance and symptoms. So more to come on that. We may see some more information about the use of Tyvaso for pulmonary fibrosis associated pulmonary hypertension. Next slide, please. So we've talked about pulmonary fibrosis or interstitial lung disease. We've talked about pulmonary arterial hypertension. Those are the two most common, but there are less common things that scleroderma can do to the lungs. So it can sometimes involve the airways primarily, particularly the small airways. So a bronchiolitis causing scarring in those small airways, and sometimes that's called constrictive or obliterative bronchiolitis. It can involve muscle. Some of patients with scleroderma have muscle disease, myopathy or myositis. And if that muscle disease happens to involve the respiratory muscles, particularly the diaphragm, then there can be a trouble with respiratory muscle weakness. As Michael mentioned, the skin, especially with diffuse disease, can get very tight. And if that's causing a lot of thickening around the chest wall, then that can impact breathing. We mentioned the effect that it has on the GI tract, the esophagus, with a lot of poor motility of the food pipe or esophagus. So there can be a tendency for regurgitation to happen. Many of you may have experienced that, where you, especially when you lay down or after you've eaten, get some of what you've eaten or drank come back up in your throat. And that's aspiration. And if that's happening repeatedly, undoubtedly some of that material can make its way into the lung and lead to damage to the lung in the form of chronic aspiration. The pleura is the lining around the lung, and sometimes that can get inflamed, but pretty rare with scleroderma, more typical with lupus and some other autoimmune disorders, for there to be pleurisy or pleural effusion fluid around the lung as a result of inflammation of the pleural surface, the thin lining around the lung. And finally, there is some increased incidence of lung cancers, particularly in people with underlying fibrosis. So anytime you have scarring in the lung, if it's over many years, that can set up some chronic irritation and can lead to the initiation of a cancerous process.
And I can speak to that because my late wife was diagnosed with stage 4 lung cancer. She had scleroderma and she didn't smoke, and it came out of the blue, and basically it was that, and a stroke took her very quickly. So it was diagnosed within 1 month, everything. There was nothing leading up, plus she was seeing her pulmonologist. So just to let people know is that it's something that can happen even when you're doing everything right.
Yeah, I'm very sorry to hear that. And I think you raise a problem in picking up cancers is, even if you're getting, you're getting regular x-rays or regular CAT scans, there's already an abnormality there, which is the scar tissue, the pulmonary fibrosis is there. So trying to detect a change of a cancer where we're looking for like a new mass that's growing in the setting of that extensive scar tissue can be quite difficult.
Yes, and like I said, it was within a 4-month period. She basically had her x-rays in June and was diagnosed at the end of November. So yeah, so just to let other people know is that it's not anything that your pulmonologist didn't do. It's just a factor, an underlying condition of scleroderma.
Okay, thank you for that. Next slide, please. So how do we screen patients with known scleroderma for lung involvement? So currently the recommendation is that once a patient has a diagnosis of scleroderma, that we get a baseline set of pulmonary function tests, we get a baseline high resolution CT, and we get a baseline echocardiogram or ultrasound of the heart. If everything is normal at baseline and the patient doesn't have any symptoms, so when we use the term screening, that implies that the patient has no symptoms. Because if there are respiratory symptoms, then you're not screening, you're actually trying to make a diagnosis. That's an important distinction. So if they're normal, then the recommendation is to get annual pulmonary function and an annual echocardiogram. Now that's a lot of testing for an asymptomatic individual, potentially over 20 to 30 years. So, I mean, I think once you've done it for several years, perhaps, you could allow doing it every maybe 18 months or every 24 months. But that's the consensus recommendations, is to get an annual pulmonary function echocardiogram, assuming that everything is staying normal and the patient is asymptomatic. And then if you see a change in the pulmonary function, then it's recommended that you get another high resolution CT scan to look for interstitial lung disease. Now, I've included, the issue of diagnosing pulmonary hypertension, I think is important to point out, because, it can be missed on an echocardiogram. So even though we're getting echocardiogram, and I showed you what we're looking for on the echocardiogram in terms of changes in the right side of the heart and then elevation in that estimated right ventricular systolic pressure. And if it's got an abnormality there, then that can make us suspicious, and we go on and work it up. But a normal echocardiogram doesn't exclude pulmonary hypertension, and this was shown pretty clearly in this DETECT study, where it was a big study to answer this question, what's the best way to screen for pulmonary hypertension? And they just took a large number of scleroderma patients who had a low DLCO. So they were sort of enriching, or, there's some suspicion that there could be pulmonary hypertension. And then they did an ultrasound or echocardiogram of the heart and a right heart catheterization on every patient, regardless of what the echocardiogram showed. And showed that 43% of patients with pulmonary arterial hypertension confirmed by right heart catheterization had a normal echocardiogram. So a normal echocardiogram, I mean, it's reassuring, but doesn't exclude pulmonary hypertension. Now, it really depends on symptoms and that in the DLCO, and that's very low. So because, and it's potentially, it's important, right? Because we do have what we feel are effective treatments for pulmonary arterial hypertension. And so, it makes sense that we want to try and detect the condition at the earliest time period, where we think our therapies are going to have more of an impact, rather than, waiting until the changes on the echocardiogram are obvious. Like that echocardiogram that I showed you, I mean, a medical student could look at that echocardiogram and say that the patient's got a serious problem. So we don't want to have to wait for that. Ideally, we want to find pulmonary hypertension before those changes have set in, and use our treatment early on. So to do that, requires, some degree of suspicion. And so we have to look at everything in conjunction, the symptoms, the DLCO, and the echocardiogram. And as Michael mentioned, the right heart catheterization is a very safe test. And, it doesn't hurt to do it, and if it's normal, it's fine. Okay, next slide, please. So what else can we do besides what we've talked about? So, any patient with lung disease, whether it's scleroderma or anything else, and whether it's pulmonary fibrosis or pulmonary hypertension, it's clearly a role for exercise in the form of a structured exercise program guided by professionals, what we refer to as pulmonary rehabilitation. So they get you in, do a basic assessment, see where you're at, and then prescribe an individualized exercise program for you, where you gradually build up to improve your basically aerobic exercise capacities. This is aerobic exercise training, just like athletes train for a marathon or for a long bike ride. Now, in the area of in the era of the pandemic, certainly may not be wise or recommended to go to a pulmonary rehab facility where there's a bunch of people around, but they have opened up, so they are available in certain places. But also, what's becoming more prevalent now is online pulmonary rehab programs, where you're live with a professional, a pulmonary rehab professional, and they're guiding you through the same regimen that they would in person at the pulmonary rehab center. Now, you're going to need some equipment, and so I would recommend that everybody, regardless of whether they have a chronic disease or not, to have some type of, especially if they have a chronic disease, I'd recommend that everyone have a treadmill or an exercise bike at home. And you get into a program and you exercise regularly. The recommendation is to try, for everyone, is to exercise 30 minutes a day, most days of the week. And if you can't do that now, you can only do 10 minutes, fine. You start and you build up, and you will improve your conditioning over time and be able to get to do more. And that's irrespective of the severity of the underlying heart and lung disease, because the exercise training doesn't do anything or much for the heart or lung disease. What it's doing is improving muscle capacity or endurance. So you're getting in shape, just like an athlete does. Next slide, please. So the benefits are to improve muscle function and blood flow through aerobic training and reverses the effects of deconditioning. And you can get increased muscle strength, perhaps, including respiratory muscles. So there's the components of the exercise program are aerobic training. And then another component is resistive training for muscle strength. Clearly, studies have been shown, and there's without question that people get improved functional capacity. They're able to do more, they feel better, and they can walk further. And there's some data suggests that it could have a direct impact on heart function and may have some anti-inflammatory and antioxidative effects. That's more theoretical. Next slide, please. And finally, we've done all these things, and the condition is severe. I shouldn't say finally. I should say that we want to understand that lung transplantation is an option. And so we want people to keep that in mind, that when the condition gets to a certain point, to consider lung transplant and consider it fairly early in the process, because lung transplantation has really grown considerably in recent years. Volumes, every year, more and more transplants are being done. Last year, over 3,000 were done in this country. And outcomes are getting better. So 3-year survival now is nationally, in the latest set of data, 74%. And I apologize just for a little bit of plug for our center, but our latest 3-year survival is 84%.
Well, the 10% difference, the people would appreciate that. Thank you.
Now, what do we know about transplanting scleroderma patients specifically? And there is some data on this. So the patients that have been transplanted, they've clearly been highly selected. It's not for everybody. There's obviously always the concern about very bad esophageal dysmotility. And I mentioned the potential for aspiration. So we do want to be careful with that, but it really depends on the transplant center, but we don't know at what degree of esophageal dysmotility or upper GI abnormalities would preclude a successful transplant.
On a footnote of that, doctor, without giving, I can't do HIPAA, but I'm an advocate and I'm very involved with the Scleroderma Foundation because of, doctors have saved my life. I've been very blessed to have a turnaround with my health. That's why I'm the advocate I am. But in the course of the year, I've had 2 people reach out to me concerning receiving double lung transplants. One of them, both of them, I sent them your information. The one had been turned down in Texas, and she passed before she could probably ever contact you. The other one was denied not only through Spectrum, but various places because of the esophageal dysmotility concerns. He has severe GERD and cannot keep it under control. And I tried to explain to people, they think that that's very a horrible way to deny somebody that. But I have, before I got my GERD under control, I'd aspirate. And, you know, you're aspirating stomach acids and bile and what into your lungs. And I said, well, if you get a brand new set of lungs and you aspirate, you're introducing, you know, foreign material into brand new lungs. I said, it's just a recipe for disaster. So I understand the screening process, but I'm not a doctor. I'm only a patient. But when somebody contacts me through my advocacy group saying desperately, I need a lung transplant, can you help me out? You know, I send them to you. I give them all your information. So, you know, that's I like I said, this is the second one I've done with you, and I have the highest respect for you. And so, like I said, I appreciate you taking the time to do this for us. So thank you.
Yeah. Yeah. Thank you very much. I mean, you know, we want people to understand all their options, you know, and so we want people to understand that lung transplantation is potentially an option.
Yeah.
And I don't know the specifics of the case you're referring to, but, you know, suffice it to say that we certainly ask about and look at upper GI dysmotility problems very closely because of the concern for aspiration after transplant with a new set of lungs that could be catastrophic.
Definitely.
But it does not preclude doing a transplant, again, depending on the severity of it.
Mm-hmm.
So, you know, we look at it, everyone on a case-by-case basis.
Sure.
But based on the published experience, you know, we look at the outcomes in scleroderma patients. They're really comparable to other patients that have other types of pulmonary fibrosis or other types of pulmonary hypertension. So, you know, they compare favorably to any other type of patient with a similar underlying lung problem. And that's all I have today.
Well, Doctor, let me just say that was very, very informative and very much, I know Michael has more experience and, like I said, helped me understand a lot more about issues that went on with my wife. And like I said, some other issues that are going on right now with some of my other family members. So I really do appreciate it.
Thank you. You're very welcome. It's been a pleasure. And thank you so much for having me.
Now with that, I'm going to let Michael wrap this up for us.
Okay. Thank you so much, Dr. Girgis, for presenting today for the Scleroderma Foundation. I know this information has been beneficial for not only myself, but everybody watching. And what a wealth of information you've provided, like I said, especially with somebody that was diagnosed with interstitial lung disease. I want to thank everybody that was viewing this webinar. Staying educated about scleroderma is so important. This is the reason the Michigan chapter strategically has created web-based educational experiences. Being educated can help the scleroderma community become better healthcare advocates. I hope you'll join us for all educational webinars. And for more information, check out our website, and it's all small letters, which is scleroderma.org/Michigan, or the National Scleroderma Foundation weekly e-letters that is delivered to your email every Friday. Thank you again for everybody for sharing your time on this webinar, and thank you, Dr. Girgis, for everything.
Okay, thank you, John and Michael. Thank you for everyone who's listening in.
Great job. Thank you, sir.